This is pharmaphorum web editor Nicole Raleigh, and I am in Berlin for ESMO 2025. With me today is Michael Lahn, who is Chief Medical Officer at iOnctura, a clinical stage precision oncology company combating neglected and hard to treat cancers with a pipeline of first-in-class small molecules. A pleasure to speak with you today, Michael.
Indeed. Thank you so much for this interview.
So, lead asset roginolisib, am I saying that right, Michael?
Very good. Yes, indeed.
Okay, is an allosteric modulator. It's being investigated in multiple randomized phase 2 studies in solid and hematological malignancies. So firstly, Michael, I was wondering if you could tell us more about allosteric modulation.
Yes, it's a bit of a unknown term, simply because the molecule does not function like the word allosteric implies. It sits outside of the pocket in which normally the activation occurs. So you have to think about it like a glove where the hands normally fit in. That would be your molecule that activates the pathways that we're looking for to inhibit. And instead of that, you're just grabbing the glove from outside and not from a different location. And that allows you to close that pocket. And we discovered this mechanism just recently through specific models and crystallography, which is a bit more of a nerdy term to describe structures on how molecules and the target interact.
Thank you for that. And what can you tell us about this lead asset?
Yeah, so this is a lead asset that we discovered over the last few years that works really well in patients where we believe this PI3 kinase, the target, is activated, and specifically this delta. And surprisingly to what generally is known about this group of molecules, we identified that it sits in a very specific location that is distinct from any other isoforms. So it allows you to block this pathway in a way that until now was not possible.
Mhm.
And so we are seeing very tolerable profiles that allow us to combine it now with a range of different standard therapies. And this was what was until now with the previous molecules not possible. And so we believe that this is what we're going to test in these randomized phase 2 studies.
Thank you. So talking about today,
Yes.
iOnctura presented today at ESMO results from the phase 1 study AON02, investigating the autotaxin inhibitor cambrita in pancreatic cancer. And that is an orally administered autotaxin inhibitor being developed for the treatment of highly fibrotic cancers, including metastatic pancreatic cancer. And that study was co-funded by the European Union and recruited patients both in Italy and the United Kingdom. So, Michael, I was wondering if you could tell us more about the data presented earlier today on this first autotaxin inhibitor. I believe it is the first autotaxin inhibitor.
It is the first in cancer.
Yes.
So yes, indeed.
Hadn't finished my question when I
Right,
asked that.
there you go.
Covering my bases. What can you tell us?
So cambritaxostat, it's a mouthful of words, you're right.
Yes, it is.
It's also unique in many ways because we were looking for a molecule that was potentially well tolerated. And so when we looked at this molecule, we thought this is going to fit the bill in highly fibrotic mechanisms that are also highly inflamed. And so we realized that perhaps pancreatic cancer has all the phenotypes, the features that we were looking to modulate and perhaps block. That was the original concept. And so this is a very, a tumor type that has escaped lots of therapeutic interventions. And unfortunately, we still are struggling to find an answer to this treatment, to this disease. I believe that the European Union has identified that pancreatic cancer is a disease that they want new treatments for. And I think we have to give credit to the European Union to take this on as a disease that needs more attention. So we believe that this molecule would do it. So what is it that was specifically looked at in this study for the first time in cancer? Number one, we looked at what this enzyme does in terms of accelerating the disease in pancreatic cancer. And there is a particular mediator or a signal that is sent out that enhances the tough or the barrier that does not allow for chemotherapy to penetrate this tumor. And we believe that we could loosen it up. And so what we observed first was that the compound was well tolerated with the chemo. This may seem not much of a topic, but if you can't get a well tolerated compound on top of chemo, then the development stops right there. So this one was the first success of this compound. And secondly, since nobody ever tested it, we had no roadmap. We had to use some of the learnings from other disease areas that are known to have a fibrotic interaction or process. And we translated that information to pancreatic cancer and saw that we were able to reduce the mediator or the product that creates this fibrotic and impenetrable barrier to the chemo. And so we were very surprised that we were able to give the chemo much longer at higher doses without necessarily inducing more toxicity. So we are actually pretty impressed with this result, and we're looking forward to continue this research.
Thank you for outlining that for me and for our viewers. So obviously we're at ESMO, thinking about that Congress as a whole.
Mm.
What are going to be the key takeaways, in your opinion, from 2025 annual meeting?
Yeah, this is always a tough one because there is so much that's happening. I would say the key takeaway is for patients in particular, it's exciting that new therapies are emerging where before we had seen nothing. So one example is ovarian cancer. When you saw today the various efforts that are happening that are potentially practice changing, this is very exciting to see that. I wish some of these things happened a few years ago. A lot of patients would have benefited. I hope that we will continue to look at these hard to treat cancers with greater interest and to open them up. And so ovarian cancer is a classical example. Then there are, of course, things that are more nerdy, like me. I like nerdy stuff.
Okay.
That's probably very exciting to see a mechanism or a technique to assess how the thymus is preserved in adults and how that could influence immune checkpoint inhibitors, so the standard of care of immunotherapy today. Now, I'm a big fan of immunology, and in the thymus, the cells that govern our immune defenses are educated and released. And if that organ, like we always assumed, vanishes with aging, then you don't have that control and enrichment portal. And so to find that this is still measurable at a certain age, even into the 30s and 40s, that's very exciting to know that you can do this with imaging. So I was very impressed with that.
Thank you. So all these things considered, these new innovations, this deeper research, what, in your opinion, will the oncological space look like in 5 or 10 years from now if we continue on this trajectory?
I think, yeah, this is, of course, trying to be the wizard here, looking into the future. Let's say two things that I feel very encouraged. Number one, we're understanding today more about biology than ever.
Mhm.
I think that the pathways towards antibody drug deliveries are going to be enhanced. So these ADCs that we're just discussing. Molecular targets are going to be certainly more and more known. For medicinal chemistry will proceed to find new ways to develop new small molecules that are better tolerated to patients. And I certainly hope that we will reinvent and re-engage with immunotherapies. Because if we want to treat cancer in a definitive way, then we have to figure out a way to enhance the immune component. That's my personal opinion. I hope we will not forget that.
Thank you, Michael. It's been a pleasure.
Indeed, thank you so much.